Now, today we'll be talking about a very interesting X-ray. Now, both of these X-rays are of same patient, but these are 24 hours apart. So the first X-ray is this, where the patient had presented with shortness of breath, which was sudden in onset. And we saw the saturation was around 84% on room air, and he was pretty rachitic. His respiratory rate was around 38 to 44, and he was a known hypertensive patient. So he was immediately put on NIV and we did X-ray and X-ray shown this. So whenever we see such X-ray of any patient who has tachypnea, whose respiratory rate is high, in what we can see in this X-ray that this patient has some perihilar haziness, which is much more present in this area. So you can see the outer part of this X-ray is like this. This outer part is kind of radiolucent compared to this area, and we can very easily and very nicely see that there is infiltration or there is opacity in a reticular pattern. There are some white linings which we can see here. So this is very much present only in much dense form around the hilum region only. So this is hilum region because the pulmonary artery, pulmonary veins, all these bronchivascular markings, these usually start from this area. The trachea divides here from around here, and the pulmonary artery, pulmonary. This is the pulmonary artery, left pulmonary artery. This is right pulmonary artery. So this area is what we call it as hilum because it is perihilar area. And the typical feature of pulmonary edema is the congestion, bilateral perihilar congestion or bilateral perihilar involvement or haziness or radio opacity, which suggests pulmonary edema and which suggests that the patient has acute LVF. The patient has acute LVF, either uh, systolic left ventricular failure, or patient may also have hypertensive heart failure where the patient's blood pressure may be very high. The treatment for pulmonary edema is pretty crystal clear. The treatment of pulmonary edema is crystal clear. As we know that there is so much of congestion, there is saturation is very low, 84. So patient needs oxygenation and patients need ventilatory support. It's very easy. The saturation is less, so we can give it by oxygen or ventilator, that is NIV, or invasive ventilator. And second thing is patient's respiratory rate is very high. If it is around 38, 44, 50, it means the patient needs ventilatory support. So if the patient is only put on oxygen, the ventilatory support will not be there. So to tackle both these problems, we can put the patients on NIV for with 100% FiO2 for some period like 1 hour, 2 hour, 3 hours, depending on how excellently he responds. And with the FiO2, the other ventilatory supports like PEEP and pressures above PEEP, they always help. So usually putting PEEP, starting PEEP of around 8 and starting pressures of 14 means usually if the lung is very compliant, what PEEP setting we put is PEEP around 5 and pressure above PEEP what we put is around 10. These are the minimum basic requirement of any patient of weight around 60 to 70 kg. This can be increased if the patient is obese, or we can simply put the patient on volume control mode. So depending on patient's weight, if the patient weight is around 60, then 60 into 6 to 8. So around 360 to 400, 420 minute volume tidal volume can be put so that his respiratory efforts can be directly reduced by the NIV. So the best treatment part for this type of pulmonary edema is ventilatory support. That is the most important. oxygen support that is already given by the ventilatory support. And second thing is diuretics, Lasix or Ditor. So such patients respond excellently to Lasix or Ditor infusion. So even 10 milligram per hour infusion for 6 hour, 8 hour, 10 hours till his shortness of breath markedly reduce causes excellent improvement in the symptoms. We can also add injection NTG in lower dosage to reduce the shortness of breath. But most of the time, this ventilator plus diuretics act as an excellent tool. Doing Foley's catheterization to measure the urine output per hour is very excellent. And if the patient is made negative by around 1500 to 2 liter also, patient's tachypnea is usually markedly improved. So we did the same thing. The patient was put on NIV for 24 hours and he was settled within 4 to 6 hours, but we still continued the NIV support for 24 hours so that his lungs get a rest, his lungs get better, his lungs get a reduced workload, because as lungs get reduced workload, automatically the heart gets reduced workload because we have shuttle of these things. So after 24 hours, when we repeated the X-ray, we can see the X-ray is much clearer than the earlier X-ray. Now, when we talk about the exposure of the X-ray, uh, these are the vertebral spinous processes. These are the vertebral spinous processes. So vertebral spinous processes, they are almost of same radio density. There is not much difference. So X-ray exposure in both the films is same, because if the X-ray exposure is less, the film will appear much white, and if X-ray exposure is more or excess, then the film will appear much black or radiolucent. So when you see the radiolucency in this X-ray, you can see this area also and this area also. They appear almost same black. So the exposure of the X-rays in this particular film is almost the same. That is the reason why whatever whitish or perihilar congestion that we are seeing, that has markedly improved in this. So the patient has improved markedly. So that's all for now. This was pulmonary edema. Thank you.